Iron overload. After learning, students should be able to understand the pathophysiology of the reactions, explain causes and effects of the events, select an appropriate laboratory investigations to help diagnosis and monitoring of medical treatments, and the most important thing is to manage and select the best blood components for patients to prevent the reaction that may occur again. Transfusion reactions can be classified into two main groups, acute and delayed, depending on the onset of the reaction. Both groups are also divided into immune and non-immune mediated based on causes. Immune-mediated reactions means that patients have existing autoantibodies specific to red blood cells, white blood cells, platelets, or plasma, while the non-immune-mediated reactions are caused by other factors. Iron overload is classified as non-immune-mediated delayed transfusion reaction. Normal body content of iron is about 35 to 45 mg per kilogram body weight in adult men, with approximately 75% bound to hemoglobin. Additional iron is present in myoglobin and several enzymes such as cytochromes, peroxidase, and catarase, and bound to transferrin, which is iron transporting protein. Iron storage in adults is mostly in form of ferritin or hemosiderin in liver, RE system, spleen, and bone marrow. Women have less iron storage than men due to menstruation. Iron is responsible for oxygen transportation and for biochemical processes such as oxidative phosphorylation, cellular respiration, and DNA synthesis. Estimated average of 1 to 2 mg per day of iron loss is in form of urine, feces, sweat, and blood loss resulting from slough intestinal mucosal cells and bleeding, desquamation of skin, and menstruation in women. In transfusion-dependent patients who need regular blood transfusion, iron overload can be occur, since 1 unit of red blood cells contains approximately 250 mg of iron, and there is no physiologic means to excrete excess iron. When the accumulation of iron overwhelms the capacity for safe storage, tissues will be damaged. Sites of accumulation includes RE system, liver, heart, spleen, and endocrine glands. Damages of accumulation sites leads to functional failure of organs, resulting in signs and symptoms. Patient at risk includes thalassemia, sickle cell anemia, and other chronic anemias. Two mechanisms are explained in tissue damages when there is iron overload. There are: first, excess iron promotes the generation of hydroxyl radicals, which induce oxygen-related tissue damage. Second, insoluble iron complexes are deposited in tissues, resulting in end organ toxicity. Typical signs and symptoms of iron overload are the result from functional failure of organs affected, including hyperthyroidism, heart failure, diabetes mellitus, growth retardation, adrenal insufficiency, liver failure, and infertility. Other signs and symptoms may be found such as arthritis, chronic fatigue, depression, hair loss, bronze skin, abdominal pain, splenomegaly, venous thrombosis, and osteoporosis. Cumulative doses of as few as 20 or more of red blood cell units are associated with increased morbidity and mortality. In transfusion-dependent patients, providing of ion chelators or therapeutic phlebotomy can reduce and prevent of ion overload. There are 3 available ion chelators which FDA approved, including desferoxamine, which must be administered intravenously, deferiprone, and deferasirox, which are both given orally. The complexes of drugs and ion molecules are water-soluble, so it can enter blood circulation and then excrete.